From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and host of this podcast episode. Melanoma incidence rates have skyrocketed around the world. Our evolving understanding of the challenges of screening the general population for cutaneous melanoma has increasingly led to strategies to identify those at highest risk and prioritize them for screening. In a new study published in JAMA Dermatology, authors describe the development and validation of a new prediction tool. It's a new prediction model for invasive melanoma in the Q-Skin cohort, with the aim of informing risk stratification strategies. Dr. David Whiteman is a medical epidemiologist at the QIMR Berghofer Medical Research Institute in Brisbane, Australia. Professor Whiteman leads the Q-Skin study, the world's largest prospective study of skin cancer. Welcome to the podcast, Dr. Whiteman.
Thank you very much for having me on your program.
So as somebody that is really into skin cancer, really into epi, really into health services research, it is awesome to have you on the podcast. I mean, you have the largest prospective cohort study of skin cancer on the planet, I think. Can you tell us a little bit about the kind of, like, how did that start? When did it start? You know, what got you involved in doing it?
Yeah, well, thank you. The cohort was conceived back in about 2008, 2009, when we were grappling with this idea of risk prediction and how to predict risk. And at that stage, all of our data really came from case control studies where you select cases and then select controls. And the underlying criticism of those studies is twofold: selection bias and information bias. You select people who are not quite representative of the population, and then those people misreport their information because of their lived experience. So we thought, let's do a cohort study on skin cancer and capture information reliably at baseline and then follow people up over time. Queensland was a perfect place to do it because of our high incidence and good social medicine, so you can track people through the system. So that's when it all kicked off, and we really commenced recruitment in 2010. So it's been 15 years now of active follow-up of that cohort.
And are you still recruiting in that cohort?
No, we're not recruiting. We did a second wave of recruitment back in about 2016 and selected another 8,000 people and obtained DNA samples from them as well. So that was our second wave of recruitment. But now it's all follow-up and sub-studies and interventions within that cohort.
Right. Basically, it's a really rich cohort to study a lot of things, risk prediction being one of them, utilization of medical treatments. And this study is no different. Actually, before we jump into the study, could you tell us a little bit about your role at the QIMR Berghofer Medical Research Institute?
Yeah, I'd be happy to. These days, I'm back doing full-time research, and your listeners will know that means writing grant applications, executing studies, supervising students, and then planning our analyses and organizing our team. So it's a really rich and fulfilling period of research. Before that, I had done a lot of administration as well, so management of research and science, which is a whole different skill set. But I really have a passion for research, and it's been my lifelong aim really is to try and bring melanoma under control and skin cancer under control in our part of the world. So it's really nice to be back working in a research environment and interacting with my clinical colleagues to try and ensure that the research we do is well-grounded and well-informed by clinical practice. So they keep us real.
That's fantastic. And so for this project that you decided to undertake, there's been a lot of talk about risk prediction for folks with melanoma in particular. Why did you feel as though there was a need to have another risk prediction tool? Because I believe there's been risk prediction tools even through this cohort that have been developed in the past. Why now? Why again?
Yeah, the issue is, as you will know, is that most risk prediction tools are really more risk stratification tools. They're not very good at predicting individual risk, even though we might talk about it in terms of individual risk. But they are very good at stratifying the population into people who are at appreciably, significantly higher risks of developing an outcome versus those people who are at much lower risks. And in our healthcare systems, we often put a lot of resource and effort into people at low risk and less effort into people at high risk. So we just want to give clinicians and public health practitioners tools that can help them at least make informed decisions about where to put their resources. And at least in our part of the world, in Australia, there's a lot of discussion right now about establishing a national melanoma screening program. Everyone recognizes that you can't screen the whole population for melanoma. It's just not effective or cost effective. But there is hope that if you can triage people at high risk, identify those people and encourage them to undergo some kind of screening test, remains to be determined exactly what that would be, then you might have a much enriched cohort in which you would be picking up melanomas and treating them early. So there's a whole conversation about this. I don't think there are easy answers, but that's the sort of context and setting in which this work was done. In terms of why now, our cohort now has 10 years of follow-up. We have over 700 invasive melanoma cases and 1,400 or so in situ melanoma cases. So statistically, power-wise, we had a big enough sample of affected people within the cohort arising newly within that cohort for us to be satisfied that we had the power to really do this properly. And so that's why we chose to do it at the 10-year follow-up.
And that 2-to-1 invasive in situ ratio seems about what you see in the general population in Australia, if I'm not mistaken.
Yeah, that's correct. Q-skin is a very good microcosm of the Australian population, or at least the Queensland population, our northernmost state. We selected that cohort at random from our population register in Australia, so we're pretty confident we've got a representative sample. They have slightly higher melanoma rates than average, but I think the relationships about the risk factors hold up within that cohort. And that 2-to-1 ratio of in situ to invasive is exactly what we see in the Queensland population. And as you have written and well know, there's a lot of reasons for that, detection being a strong part of that.
Yeah. So when you're building a model in order to risk stratify, what are some things that you do to try to develop that model? Because a lot of our listeners might not be very familiar about how models may work. How would you explain to them the basic mechanics of what you decide to include in a model and what that ultimately tells you as a clinician, or what that can help you in counseling your patients around, whether to get screened or not?
Yeah, I think there are different schools of thought about how you go about these model building processes. We followed the very conventional tripod statement, which is one of these published consensus documents on what constitutes good model building practice for clinical risk prediction in the modern setting. So that's kind of the Bible that we followed in doing this. But simply put, we have a cohort of a bit over 40,000 people. At baseline, we excluded the people who'd already had a melanoma. And so we were following people up for a new episode of histologically diagnosed melanoma. We had about 700 new cases arise in that 10 years. And so then we compared essentially those cases, their characteristics, with the people who did not have a melanoma. And because Q-skin was designed as a cohort study that was addressing skin cancer, we had very rich phenotype information on that population. And this is the advantage of Q-skin, I think, over other cohorts that are out there, because we collected information about nevus density and freckling and hair color and eye color, which many other cohorts around the world, Framingham and others, Nurses Health Study, they haven't really got those at baseline.
Even ancestral risk.
And we have ancestral risk. And so basically at the start of the model building process, all of those variables go into the soup, really, of the statistical model. And then through complicated processes of backwards and forward selection, the most parsimonious, the most telling variables are retained in the model through statistical testing. And so then you end up with a model, and ours ended up with 16 terms in that model that all were statistically significant after adjusting for other variables in the model. And so that's part one, is developing the model. Part two is validating the model. And that's always a challenge.
So can I pause you on the first part, developing that model? Anything surprise you about the 16 predictors that fell out? Some will probably not surprise many people, like hair color, freckling, tanning ability. But were there any others that rose to the top that were like, wait a second?
Yeah, there were some sort of surprises, but not really when you unpack it all. As you say, the obvious things were in there: nevus density, freckling density, hair color, ability to tan, how many sunburns you'd had. But the two, I guess, that will raise eyebrows, one was smoking status and the other was height. Smoking actually has an inverse association with melanoma.
Hmm.
We've seen that in previous studies that we've done. It's in the literature. And more recently, Mendelian randomization studies, genetic studies testing this, as the underlying genetics of both smoking and melanoma,
Mhm.
also find this inverse association that smokers have a lower risk of melanoma for whatever reason. We honestly don't know why that is, but it's not, we think, due to bias or confounding. There seems to be some thing about smoking that has an effect on melanocytes that just seems to stop them becoming malignant melanomas.
Yeah, I saw a hypothesis that it somehow alters how the immune system may immune surveil the skin. Again, this is all a hypothesis, and we would never advocate for anyone to
Absolutely not.
start
Absolutely
smoking
not.
to
No.
prevent melanoma. But
But it's just that in a risk prediction tool, if you have information on smoking, it does improve the performance of the prediction tool. So it's, as you say, you'd never have a public health intervention around smoking to prevent melanoma, but it certainly improves the precision of the tool and significantly does so. The other one was height. So we have found, and others have found as well, that there is a positive association between height and risk of melanoma. And that's also been backed up by these Mendelian randomization genetic studies. People who are genetically taller have a genetically higher risk of melanoma. And that's been seen in a number of studies. So again, those two terms are not often ever found in previous risk prediction tools. And it's not to say that other tools are inferior, but we have found that by including these terms in the model, the precision and the performance and the calibration improves. So they're not noise, they actually add predictive value. So from that point of view, they retained in the model.
what do you think about height? I have my own reason why I think height is predictive, but what do you think is about height?
Well, height is a very interesting one. It comes up for a number of different cancers. So there are schools of thought that maybe this is just related to the total number of cells in a human organism, that probability-wise, if you have trillions more cells occupying a volume and a mass, then statistically you have a higher risk that one of them will go rogue and turn into a melanoma. That's a simplistic argument. I don't know if that's true, but that's
Mhm.
the sort of textbook simple hypothesis to explain that.
Well, I'm a simple guy, so
It- it-
I buy that. I buy that hypothesis.
but I honestly don't know. And it's probably to do with signaling pathways and, all of these sort of cytokines or prostaglandins.
Your ability to grow a certain height, maybe.
Yeah, and maybe it's to do with the age at which you grow as well. We know that melanomas are a bit of an unusual cancer in that they have a fairly long latent period, and it seems that there's quite an intense period of initiation activity earlier in life, maybe corresponding with a growth spurt as nevi are becoming prominent as well on the skin and teenagers go through a growth spurt. Maybe there's some connection there. I really don't know, but it would be an area worthy of research. It'd be a difficult question to answer, but I think there's something in there. It just doesn't go away.
Your total body surface area is probably a little bit bigger, so
Yeah, well, that's
just
true.
more.
Although we didn't see it with BMI. So BMI
You did not. Okay.
and it's driven by height and not by mass, if you know what I mean. So as far as we can tell with crude anthropometric measures. So it's an interesting one to unpack, I think.
So let's get to number 2, the validation. After you developed this model, where did you validate the prediction model?
And this is the great challenge. Ideally, you would externally validate. You would find another data set, another cohort, and you would do it in another cohort. But as I said, the challenge we have for melanoma in particular is that most other cohorts don't have information on nevus density, freckling density, eye color, these sorts of things. And in fact, even a bunch of case control studies have less information than we have on things like height and smoking in their melanoma case control. So we had to do internal validation, which is using statistical resampling techniques called bootstrapping. So you dip into your cohort of 40,000 people 1,000 different times, and you pull out random numbers of people. You just keep sort of sampling that data set. And so you get then random variation internally in that data set, and you repeat your model building process and you repeat your model prediction process. And then it gives you statistical outputs on how consistently you will arrive at the same answer. So it's the less good option for internal validation, but at least it tells you, are there some factors that are just driving this model selection process and driving it out of whack? And we didn't see that. We saw that however many times we resampled within our data, we ended up with pretty much the same list of variables with pretty much the same effect sizes, leading to pretty much the same predictive ability. So there's some variation around that, of course, statistically, but we were reassured that it wasn't due to some aberrant patterns in the data, but it awaits testing in an independent cohort, and we would welcome that. And we're going to try and get that done however we can. We did a second wave of recruitment in 2016, so we are holding that aside as our validation cohort, but that's not yet mature enough to have enough episodes of invasive cancer yet to be able to test it. So we're going to put that on hold for a couple of years and then retest this new model in that fresh cohort.
And how can a clinician use this model if they wanted to? Is it something they could plug into a website? What do you do with it?
Yeah, so we're working with our production team to make the model available online. Our earlier model already is available online, but our new model is just being worked through that system. So it will be available online. You can do it on your phone, and I guess in time we'll have a platform or an app. The intent here, and particularly in Australia where there is a lot of concern about melanoma, there's a high patient awareness as well. So people themselves, the consumers, patients will be the biggest users in Australia of this tool, and they will kind of self-select to be either screened or not.
Mm-hmm.
So another piece of research we're doing right now is how much does using a tool like this actually change your knowledge, your attitudes, and your behaviors? It might well be that regardless if people are even told they have a low risk of melanoma, if they're worried enough, they're still going to demand to be screened.
For sure. Actually, in Austin, Texas, I have an abnormally large amount of patients that are from Australia.
Do you?
So,
Okay.
yes.
Well, they
yes.
probably know the melanoma doctor and they go, right, I'm going to see that fella.
Right.
He knows what he's talking about. So yes, there's a lot of work to be done now on that implementation side. That's really where the rubber hits the road, I think.
And one really interesting thing about your paper, I would say, is in table 3, where you look at the predicted risk kind of decile and kind of calibrate the number needed to screen to, I guess, find a melanoma. Can you just briefly discuss that? So readers that might not be as familiar with this kind of analysis, what the take home is.
Yeah, so this is really the table that I think would be of interest to people in policy type areas when they're saying, okay, great, we've got this tool. What does that mean if we roll this out in an insurance plan or in a population? And so what we've done here is divide the population into 10 groups of equal size based on their predicted risk of melanoma from using the tool. And so what that table shows is that people in the top 10% of risk, there's a column there that says sensitivity. That's reporting essentially that 33% of all melanomas arising in our cohort arose in that top 10% of risk in the population. So if you just had a stratification practice or policy that said, we're only going to screen the people in the top 10% of risk, you'd still find 1/3 of all melanomas arising in Queensland. So you'd only need to screen 18 people in the population to find those cases of melanoma. So then you can go down those deciles, and there's a column there called the Uden Index. This is a statistical tool that's used to help people decide where they should draw the line. So in our tool, in our population, that line was drawn between the 6th and the 7th decile. So in the top 40% of the population, you optimize the sensitivity and specificity. And in that way, you pick up about 3/4 of all melanomas by screening just the top 40% of the population. So, that then gets into health economics and the costs of doing this and the benefits of doing it. But at least that's a starting point for discussions. It helps people work out how many melanoma cases am I going to find if I just restrict screening to a certain proportion of people that have arbitrary risk of melanoma.
I agree. And I think that's a really important starting point for discussion. Where can we actually set the bar to find this high-risk group, right? The people that are most likely to benefit.
Yeah, and this will actually likely change across different populations. So these sorts of tables would need to just be ensured that they do calibrate in different populations with different mixtures of people with different ancestries and different phenotypes. So these are indicative for Australia. Australia is a fairly diverse population, but we know that Q-skin is a little less diverse than the population generally. So it would be very important, I think, that other sources of data are obtained when using this tool so that the table can be calibrated for the population that's being considered.
And the one provocative thing, I can't let you get away without asking this, is what about death? What about making a model to try to predict, the people that may have a lethal melanoma and trying to identify those people? I don't know if that's even possible.
Yeah, and it's not provocative. It's really, in a sense, almost the obvious question, really, because as we're all concerned, there's a lot of overdiagnosis of melanoma. Melanoma largely has an extremely good prognosis when diagnosed early. And so we're really concerned about proxies for death, at least, so thick melanomas in particular. We are working on that. We don't have it yet in our paper because fortunately, in Queensland and in the US, the proportion of people presenting with thick melanomas at first presentation is actually very, very low. And so we are doing everything we can to learn more about who those people are. Why are they presenting late? Is it because of the tumor? Is it because of the location of the tumor? Is it because of where these people live? Is it their access to healthcare? What is it? And so that's a live research analysis that we're doing right now. So we'll have an answer for that question in the not too distant future, I hope.
We're looking forward to it. I am Dr. Adewole Adamson, and I've been speaking with Dr. David Whiteman about the development of this new melanoma risk prediction tool. You can find a link to the paper in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.